Hi everyone, today we'll discuss about gastric volvulus. First, coming to the gastric anatomy, the stomach is divided into the region of the cardia and the fundus, the body, the great antrum and the pylorus. So this is the greater curvature and this is the left curvature. Along with these curvatures, you have the blood vessels supplying the stomach are running. So on the lesser curvature, you have the left gastric artery and the right gastric artery. Along the greater curvature, upper part you have the short gastric artery and the lower part you have the right and left gastroepiploic arteries. So coming to the relations, so you have the attachments of the stomach, that is gastrohepatic. You have the gastrohepatic, the gastric and the hepatic, and the gastrocolic between the stomach and the colon, and you have gastrosplenic and gastrophrenic is to the diaphragm, and there is the retroperitoneal duodenum and gastroesophageal junction. So all these ligaments help in holding the stomach in its position. So coming to the definition of gastric volvulus, it is the rotation of the stomach or portion of the stomach at least more than 180 degree along its longitudinal or transverse axis. So coming to the classification, you have two types of classification. One is anatomical. The first is organoaxial. So organoaxial is the most common and it is seen in 2/3 of patients. So you have a line joining the gastroesophageal junction and the pylorus. So this is the long axis of the stomach. So there is rotation of the stomach along its long axis. So what happens if it is so? So the antrum will come anteriorly. So A for A, anteriorly and goes superiorly. So this part of the antrum will start moving upwards, and then the fundus, which is above, will go posteriorly and inferiorly. So this is the fundus which goes posteriorly and inferiorly. So there is twisting up of the greater curvature and strangulation is more common in this type of gastric volvulus. So the next type is mesenterico-axial. So this is nothing but a line drawn in the middle of the lesser curvature to the parallel of the omentum. You have the gastrocolic omentum which is running here. So it is parallel to this omentum and the middle of the lesser curvature, and you have the pylorus which is rotating. So it is just like folding the stomach from below upwards. So the pylorus rotates anteriorly and superiorly. You can see the pylorus here, anteriorly and superiorly. So coming to the next classification is whether it is a primary or secondary. Primary, it is seen in 30% of patients. The most common variety is mesenterico-axial. So here the causes are asplenia or wandering spleen or congenital defects in the ligaments which are supporting the stomach. The secondary is the most common, and in that organoaxial is most common. So the most common cause is paraesophageal hernia. So coming to the symptoms, so there is a classical triad called as Bouchard's triad, which consists of severe epigastric pain and distension. So severe epigastric pain and distension in any hollow viscous organ undergoing ischemia. So there will be an unexplainable severe pain with no peritonitis sign. So it is same for the stomach. They will have severe epigastric pain and distension because there is obstruction at the pylorus, and due to obstruction there is lot of vomiting followed by retching, and you will be unable to pass the nasogastric tube because the stomach itself is rotated and there is obstruction to the pathway, so there is so you are not able to pass the nasogastric tube. So there is one more variety called as the intrathoracic gastric volvulus, because you know that the secondary gastric volvulus, the most common cause is paraesophageal hernias. These especially in type 4 paraesophageal hernias, you find these type of intrathoracic gastric volvulus causing chest pain, shortness of breath and mediastinal compression, can even cause arrhythmias. So coming to the investigation, how do you diagnose it? The first modality is X-rays. So coming to the normal X-ray, so you can see the fundus, body, pylorus and greater curvature and lesser curvature in this X-ray. So coming to the next X-ray, so showing you the gastric volvulus. So positive the distal bowel gas, because there is obstruction, there is no distal bowel gas which is normally seen. And above the diaphragm, see this is the diaphragm, so above the diaphragm you can see the air fluid level. And the next thing is reversal of the relative position of greater and lesser curvature. You know, this is the greater curvature which has to be lying down here, so there is a relative transposition of the greater curvature and the lesser curvature. And the pylorus is always pointing upwards, but here you can see the pylorus is pointing downwards. So the next modality is CECT. So CECT will give you the exact picture of the cause of the gastric volvulus, such as predisposing factors, as if there is any kind of absent spleen or wandering spleen or paraesophageal hernias or lack of attachments. Those things can be made out in the CECT. And gastric pneumatosis, that is the air pockets in the gastric wall, can suggest you the ischemia and the need for emergency surgery. So coming to the treatment, so patient should undergo immediate resuscitation followed by laparotomy. So in the laparotomy you should first reduce the gastric volvulus. The main surgical principle is reduce the volvulus and fix the, if it is gangrenous, then you patient might need gastrectomy if the stomach is gangrenous, depending upon how much of the stomach is involved. So it can be total, subtotal gastrectomy can happen. And if the stomach is still viable, so you have operated at an early stage, so if it is viable, then gastric fixation to prevent recurrence. Thank you.